Hello, dear students. Today we're going to talk about acute appendicitis. This is your lecturer Shevchenko Alexander, Baltic Federal University, Medical Institute, Kaliningrad, 2020. So, uh, this is very important theme because inflammation of the appendix is a significant public health problem with a lifetime incidence of 8.6% in men and 6.7% in women, with the highest incidence of common in the second and third decade of life. While the rate of appendectomy in developed countries has decreased over the last several decades, it remains one of the most frequent emergent abdominal operations. So, what is appendicitis? Appendicitis is acute inflammation of the vermiform appendix. As you know, if you see on the end of the word ending itis, it means inflammation from Latin. What is etiology and pathogenesis of appendicitis? The etiology of appendicitis is perhaps due to luminal obstruction that occurs as a result of lymphoid hyperplasia in pediatric populations. In adults, it may be due to fecalitis, fibrosis, foreign bodies, food parasites, calculi, or neoplasia. Early obstruction leads to bacterial overgrowth of aerobic organism in the early period, and subsequently it leads to mixed flora. Obstruction generally, early, obstruction generally leads to increased intraluminal pressure and referred visceral pain to the periumbilical region. It is postulated that this leads to impaired venous drainage, mucosal ischemia, leading to bacterial translocation and subsequent gangrene and intraperitoneal infection. Escherichia coli and Bacteroides fragilis are the most common aerobic and anaerobic bacteria isolated in perforated appendicitis. The sequence is not inevitable. However, in some episodes of acute appendicitis may resolve spontaneously. Due to differences in epidemiology, non-perforated and perforated appendicitis are considered different diseases. Additionally, since not all perforated appendicitis progresses to perforations, it is suggested that the pathogenesis of the two conditions may be different. So clinical features, it's migrating abdominal pain. This is the most common and specific symptom. This symptom called Kocher sign. Typically constant and rapidly worsens. Most patients present within 48 hours of symptom onset. Initial diffuse preumbilical pain caused by the irritation of the visceral peritoneum. Localized to the right lower quadrant within 20 to 20, 24 hours caused by the irritation of the parietal peritoneum. McBurney point tenderness or right lower quadrant tenderness. Uh, Tenderness at the junction of the lateral third and medial two-thirds of the line drawn from the right anterior superior iliac spine to the umbilicus. This point corresponds to the location of the base of appendix in most of the cases, but not in the all. We talk about it later. Right lower quadrant guarding or rigidity, rebound tenderness, Bloomberg sign, especially in the right lower quadrant. Rosen sign, right lower quadrant pain elicited on deep palpation on the left lower quadrant because inflamed appendix will be touched by the gases which go from the uh, sigmoid colon to the cecum. It air which going from the lumen of the uh, colon and irritates the uh, appendix vermiformis. What we can use for laboratory studies? Uh, it's mild leukocytosis with left shift. Mm, Normal white blood cell count does not rule out appendicitis, acute appendicitis. C-reactive protein is elevated more than 10 milligrams per liter. Maybe elevated creatinine. Electrolyte abnormalities may be present in patients with severe vomiting and diarrhea. Urinalysis typically normal in appendicitis. Possible findings of mild pyorrhea and hematuria. Test to rule out differential diagnosis. It's urine serum beta human chorionic gonadotropin test performed in all women of reproductive age to rule out pregnancy, including ectopic pregnancy. In morphological classification, we can use three phrases: cateral, phlegmonous, and gangrenous. If you see red with wide vessels, uh, appendix vermiformis, it means it's cateral appendicitis. This appendicitis on the early onset, and most of the cateral appendicitis must not be touched because maybe the reason of abdominal pain is not appendicitis. You can see this appendicitis uh, on the first picture. On the second picture, you can see phlegmonous appendicitis. It's thick wall appendicitis. It's swollen, and maybe you can see some purulent uh, or fibrogenic mm, coverings like these black sheets here on the appendix vermiformis and gangrenous appendix. As you see it necrotized part. Uh, do you know what's the difference between gangrenous and necrotized organs, and why we have um, necrosis of the brain, but we can also have gangrene of the leg and the lung, and never have gangrene of the liver? We have only liver necrosis. I give you some time to think about it. Okay, all organs which we call necrotized, they didn't correspond with the air. And as you know, our bubbles correspond with the air through the lumen of our bubbles. Through the mouth and anus, they correspond with the air. And this example, of course, we can talk about gangrene of the lungs, gangrene of the bowels, and never we can talk about gangrene of the spleen. It will be necrosis of the spleen. So, where is uh, appendix placed? Appendix placed on the McBurney's point. It's placed between uh, distal third uh, between our umbilical and uh, upper superior iliac spine, distal third. This is most common position of our appendix, but you must understand that it can be retrocecal. It's behind the cecum. It can be retroperitoneal, behind the peritoneum. It can be uh, below the liver or behind the liver. It can be pelvic, and it also can be on the left side. It's not frequently, but if you know embryology well, you know that uh, our bowels must rotate uh, for 360 degrees, and sometimes this rotation it's not well ended, and our appendix, our patient can have appendicitis from the left side. You can see most of the time in the United States, for example, they have early surgery because uh, many of these patients have bowel obstruction because the leads band which fixed these bowels which didn't rotate well, and in early age patients have bowel obstruction. uh, we have special procedure called Ledder's procedure. We dissect this Ledder's band, and most of the time we must provide appendectomy because it's a little bit confusing when the people have very intense pain from the left side and no sign of perforation or abdominal mass. So we didn't know what happened. Maybe it perforated the verticulus, but I remember one patient who go to the emergency hospital here in Kaliningrad and say he have uh, peptic ulcer which perforated maybe 30 years ago, and the surgeons told him that you have appendicitis from the left side, and he gave me a very old document with stamp in which code in which says that he have appendicitis from the left, and it was signed by some surgeon I didn't know from where he come here, but it was a very interesting case. What we can say in pathologic anatomy: as you know, appendix have mesoappendix, serosa, longitudinal muscle, circular muscle, submucosa, as all luminal organ, and of course it have very thick lymphoid nodules and crypts of lubricant. What we can see in microscope in low magnitude and in high magnitude. How we can say this is acute diagnosis of acute appendicitis. This is hematoxylinosin dye. As you know, our neutrophils become blue, so you can see many of them. We can convert on this picture uh, diagnosis of acute appendicitis. Mm, in this case, it's acute appendicitis in 10-year-old boy. The organ is enlarged and sausage-like, butyliform. This longitudinal section shows a red inflamed mucosa with an irregular luminal surface, diagnosed and removed early in the course of the disease. This appendix does not show late complications like transmural necrosis, perforation, and abscess formation. I forgot to delete this for you. Sorry. So on the left you can see catarrh, appendicitis, no fibrin, no purulent contains coverage, gangrenous appendicitis because one side of this appendicitis is destroyed by necrosis, and this is most common reason of acute appendicitis in adult age. It's fecalites. Fecalites, it means a very thick and dense stool which go to the lumen of the appendix, and it blocked it, and gut flora become more and more uh, wide, and try to uh, disrupt this organ with time. This is an inflamed retrocecal appendix with adhesions. As you see, this is adhesions. Adhesions, this is a protection reaction of our peritoneum to inflammation. Every operation uh, lead to adhesions. And this is appendiceal abscess. As you see, we didn't see properly uh, where it placed appendicitis. Maybe this, and it covered um, with amentum as well. What about what we must think in case of differential diagnosis? It's acute mesenteric adenitis, diverticulitis, diverticulitis, acute ileitis, Crohn's disease, acute pelvic inflammatory diseases, torsion of ovarian cyst, or Graafian follicle and acute gastroenteritis. Frequently, no organic pathology is identified, obtaining an antecedent history of a viral infection, mesenteric adhesions, adenitis, or gastroenteritis. And the cervical examined woman exquisite tenderness with motion and pelvic inflammatory disease, and the essential uh, planning and any intervention. You must take detailed menstrual history and can distinguish metal schmerz. No fever or leukocytosis, mid-menstrual cycle pain, and ectopic pregnancies. As you see on this picture, it can be also aortic aneurysm, ovarian cyst, and many other reasons like ureteral calculi. So, treatment. Preferred approach, as you see on this picture, it's preferred approach to uncomplicated appendicitis. It's surgery. We have another method, short course antibiotic treatment. Meta-analysis of the published data found that 26.5% of patients in the non-operative group required an appendectomy within 1 year. So we didn't recognize this method as a valid decision in case of acute appendicitis. It very important. Another question: timing of surgery. We can define surgery less than 20 hours. Unacceptable in patient with short duration of symptoms, less than 48 hours. And in case of non-perforated and non-gangrenous appendicitis. You can ask how we can say if this appendicitis is perforated or non-perforated. It's very easy to understand because we have special CT scan, we have ultrasound, use it well, use it in the case of not distinguished acute abdominal pain as well. Numerous meta-analyses comparing laparoscopic to open appendectomy and have demonstrated relative equivalence of the techniques, with laparoscopic appendectomy resulting in a shorter length of stay, faster return to work, and lower superficial wound infection rates, especially in obese patients. Complications. Complication, it's sorry. I want to say a few words about antibiotic treatment. You can use as antibiotic cephalosporin with anaerobic coverage. In patients who allergic to cephalosporin, you can use metronidazole and ciprofloxacin. Uh, we have five different complications: pilophlebitis, gangrenous appendicitis, perforated appendix, appendiceal abscess, inflammatory appendiceal mass, appendiceal phlegmon. Uh, don't look on pilophlebitis, please, because it's more rare complication in case of appendicitis. It's not common. What is inflammatory appendiceal mass? It's a new defined mass of inflammatory periappendical tissue. Manifest as tender mass in the right lower quadrant. It's we can use non-operative management of acute appendicitis. And after 6 weeks, so we give our patient 3 days intravenous antibiotics, and then we give them per os antibiotics for uh, 6 weeks. For 7 days, sorry, and then after 6 weeks we can operate this patient. Appendiceal abscess. It's localized collection of pus and necrotic tissue that forms around an inflamed appendix, which typically follows as an untreated perforated appendix. Manifests as a tender mass in the right lower quadrant in an acutely ill patient. It's a high-grade fever. It's patients with a high-grade fever, possible paralytic ileus, leukocytosis, and signs of sepsis. Treatment, you can give the patient you can give intravenous antibiotics for 3 days, and then you must uh, give 7 days per orally uh, antibiotics, and then in 6 weeks you must operate this patient. If you can see on CT abscess is less than 4 centimeters, antibiotic therapy alone is usually sufficient. If abscess is more than 4 centimeters, image-guided percutaneous drainage of surgical drainage centers you must consider about this. And then you must consider the uh, do we need early operation, because in most of the time we must uh, stay for wait for 6 weeks and then operate, because if we try to operate early we didn't do anything because all bowels covered the appendix, and if we try to dissect them we can do more harm than benefit from this operation. Perforated appendix. As you see here, a hole in the wall of appendix with fibrinose and purulent contains. It's perforated appendix, it's rupture of the appendix. Early presentation, it's localized peritonitis and decreased bowel sounds. Generalized peritonitis indicates a free rupture of the appendix into the peritoneal cavity. Localized peritonitis suggests concealed perforation. Delayed presentation, appendiceal mass or appendiceal abscess. Treatment, it's emergency appendectomy with intravenous antibiotics. Obtain pus or exudate cultures intraoperatively. And if you see appendiceal abscess or appendiceal phlegmon, uh, you must consider interval appendectomy. It's operation after intravenous and peros antibiotics, and then uh, operation in 6 weeks. Gangrenous appendicitis. It's a reversible necrosis of the appendiceal wall. It's manifest with high-grade fever, tachycardia, severe right lower quadrant pain, and tenderness. Typically diagnosed intraoperatively, these appendix have a moderate purple appearance. Treatment is emergency appendectomy and intravenous antibiotics. And pylophlebitis. What showed on this arrow? It's a blood clot on the portal vein. So it's septic thrombosis of the portal vein or its branches. A complication of intra-abdominal sepsis due to perforated appendicitis, diverticulitis, or necrotitis, pancreatitis. Clinical features, it's fever, abdominal pain, most often in the right upper quadrant. We can use CT for diagnostic. We must send our blood to sterility because we can have bacteremia. We can treat it with broad spectrum antibiotics, but this is severe complication. And we must talk in short about appendicitis in special categories of patients. So what's wrong with appendicitis in children? Uh, the reliability of signs and symptoms in children is lower. Most reliable symptoms, emesis and durations of pain. Most reliable signs, abdominal tenderness and pain with walking, jumping, or coughing. Ultrasound is the diagnostic procedure of choice. I sent to you video how we can well define the appendicitis of acute appendicitis with ultrasound, but you must understand we cannot use it to well define um, normal appendicitis because it's very difficult, as you see on this video which I send you. What's wrong with appendicitis in pregnancy? It's atypical higher pain because pregnant uterus um, become big and it lift our appendicitis higher and higher. Most often, if it's late pregnancy, 7 month or 8 month, you can find appendicitis below the liver. In this case, ultrasound is the diagnostic procedure of choice. It's perforated if we have case with perforated or gangrenous appendicitis. It's associated with the higher risk of fetal loss. Appendicitis in patients, in seniors or older patients, and have possible low-grade fever. It's have confusion, subtle abdominal guarding. Older patients are more likely to develop complication, especially perforated appendicitis. Imaging should be considered regardless of the scores. Consider diagnostic laparoscopy if imaging findings are non-conclusive. Consider colonoscopy after treatment of acute appendicitis to rule out early colonic malignancy. And very controversial definition, chronic appendicitis. It's patient with recurrent right lower quadrant abdominal pain, not associated with a febrile illness, with imaging findings suggestive of an appendicolith or dilated appendix, are classified as having chronic appendicitis. Patients often report resolution of symptoms with an appendectomy. In the absence of imaging abnormalities, prophylactic appendectomy is not encouraged. And gastroenteropancreatic neuroendocrine tumors or GIPNETs or carcinoid. Appendiceal carcinoid tumors are submucosal rubbery masses that are detected incidentally on the appendix. Carcinoid tumors of the appendix are relatively indolent but can develop nodal or hepatic metastasis. Infrequently, these can be associated with a carcinoid syndrome if there are hepatic metastases. Upon incidental findings of unsuspected carcinoid, the most surgeon must evaluate the nodal basin along the ileocolic pedicle and also examine the liver for any signs of metastasis. Lesions that are less than 1 centimeters. A negative margin appendectomy is adequate. For most tumors, 2 centimeters or larger, and right hemicolectomy is recommended. For lesions from 1 to 2 centimeters inside, there is no consensus on a complexion colectomy. A right colectomy is often performed for mesenteric invasion and large nodes or positive or unclear margins. Measurements of serum chromographine A is recommended. In summary, acute appendicitis is acute inflammation of the appendix, typically due to an obstruction of the appendiceal lumen. It is most common cause of acute abdomen requiring emergency surgical intervention in both children and adults. The characteristic features of acute appendicitis and periumbilical abdominal pain that migrates to the right lower quadrant, anorexia, nausea, fever, and right lower quadrant tenderness, when seen alongside neutrophilic leukocytosis, these features are sufficient to make a clinical diagnosis using appendicitis scoring system to estimate the likelihood of appendicitis. Imagine encephalography abdominal CT with intravenous contrast abdominal ultrasonography may be considered if the clinical diagnosis is uncertain. The current standard of management of acute appendicitis is emergency, appendectomy, laparoscopic or open, and antibiotics. Non-operative management of inflammatory appendiceal mass or phlegmon or an appendiceal abscess because surgical intervention is associated with a higher risk of complications in these patient groups. Interval appendectomy take 6 or 8 weeks following resolution of acute episode and may be considered in those patients to prevent a recurrence of or if in concern for an underlying appendiceal tumor. Thank you for your attention. If you have any questions, you can send me in the LMS chat or in WhatsApp. So I hope we can meet in the WebEx on our Saturday because we have lectures on Saturday and you can ask me any question about first and second lecture and we talk about new team on Saturday. Goodbye.